Hi, my name's Jason Chandler, and I'll be doing updates in malignant hematology for this APP conference. All right, so we're gonna pick just a few different topics. I didn't want to do all different malignant hematology, just kind of too many topics to choose from. So I picked some relevant changes in the management of patients in the upfront setting and relapse refractory. So we'll go over diffuse large B-cell lymphoma, both newly diagnosed patients as well as those that are relapsed and refractory. We'll talk about multiple myeloma and the use of CAR T. Initially, it was approved in like multiply relapsed patients, and then more recently, it got approved in the second line setting. And then finally, CLL and some new treatment options in an upfront setting. Okay, so first we're going to talk about the Polarix study. And so this is a new, I think, shift in the standard of care for treatment of upfront patients with diffuse large B-cell lymphoma. For years, R-CHOP was the standard. They tried many, many times to unseat it from its kind of preeminent place. They tried to add drugs, do them more often, and every time R-CHOP came out as the winner. And so then finally, a few years ago, this Polarix study was adding polatuzumab, which was an antibody drug conjugate. And it does have some neuropathy issues. So what they did is they took out vincristine and they replaced it with the polatuzumab. So the only kind of inclusion criteria, you had to have an IPI of 2 or greater. And so it's pretty easy, just an LDH that's elevated or age over 65, just a couple of elements to make the patient just a little higher risk. And basically you got 6 rounds of R-CHOP or 6 rounds of Pola-R-CHP. And basically on the left was kind of disease-free survival, and on the right, overall survival. And although the overall survival curves are overlapping, fewer patients relapsed, and it was clinically significant with Pola-R-CHP than R-CHOP. And that means fewer patients that have to go on to stem cell transplant or now for CAR T. And so basically, if you use this treatment up front in all comers, there's lower risk of relapse. And they followed it out at 5 years, and you can see that the curves stayed separated all the way out to 5 years with Pola-R-CHP versus R-CHOP. So the side effect profiles were pretty similar. Even neuropathy were pretty close. Infection risk, pretty close. There was not a lot of increased signal over R-CHOP. Of interest was a kind of subset analysis. So if you look, it shows the different subtypes, and the line in the middle, if you look to the right, that would be R-CHOP would be better, and to the left, Pola-R-CHP better. And in this one section, they talked about ABC type patients. They seem to get a lot of benefit from the Pola-R-CHP, whereas the GCB, it seems to be kind of the same. And so I wanted to bring that to everyone's attention because in the study, if you hear about this regimen and say, oh, it only works for this group, in that study, they used gene expression profiling. So they used expensive tests, which you don't really have in clinical. It's not available just in clinical practice. And they do this expensive gene expression profiling to say that this is an ABC. So if we ever get to that, I think we could subset those out, and maybe GCB could get R-CHOP and the other one could get Pola-R-CHP. But what we use in clinic is this kind of a version that just is a surrogate, and it just used staining on the surface of the cells. And so in the paper that came out, they basically said, if you use this methodology and only pick those to treat with Pola-R-CHP, you're probably going to miss a lot of patients that get benefit from it. So I think the take home is upfront, diffuse large B-cell lymphoma, all comers, Pola-R-CHP is better from a progression-free survival version benefit, and maybe not overall survival, but you'll have less patients going to transplant or for CAR T afterwards with about the same side effect profile. Yeah, and that's basically what we said here. All right, and so this is just an interesting study. These are all the different studies that are ongoing, going back from 2017 until the future. So you can see Polar R chip, and actually, like we participated in Polar R chip, and then we participated in the Frontmind study, which was adding tafasitamab lenalidomide, and then we're on the Sky Glow study that just finished, which is glofitamab versus with Polar R chip. So they're keeping on trying to do more and more, and there's just ongoing studies trying to do better and better. So maybe we'll cure more and more of these patients. Okay. So what if a patient does relapse after their R-CHOP or Pola R-CHIP? So there's these new treatments out. There's BiTEs and there's CAR T. So they can be used for different disease types, both for multiple myeloma, multiple lymphomas, um, ALL, even CLL. So the way it works is you have the cancer cell and there's something on the surface of it. And then these are like normal, like plasma cells. Um, and so a BiTE is it's bispecific T cell engager. That means one side sticks to something. In this situation, it's BCMA that's on a cancer cell or your normal plasma cells. And the other side sticks to a T cell. So it takes a T cell and pulls it right up next to the target and gets it activated and mad so that it'll kill its target. So the BiTE is a drug you give, and it temporarily pulls the T cells next to the cancer cells and makes them fight. And so it works great. So these BiTEs will kill off your cancer cells, and they do have the potential side effect of activating your immune system almost like it's an infection. It can almost look like sepsis. We call it CRS or cytokine release syndrome. But basically, your body is having fevers, chills, body aches. And so the idea with these drugs is you want to give a little dose, a little higher dose, and a little higher dose to kind of ease into that so your body doesn't get all of that reaction at once. And so this works for myeloma patients, sometimes lymphoma, where we'll admit them or observe them closely for this cytokine release syndrome, if you've heard about it. So for CAR T, it's the similar principle, except what you do is you take those T cells and then you manufacture them or put little DNA in them using a virus so that they recognize a new target. And then they, instead of just pulling your normal T cells to it, these engineered T cells are able to fight the target. And so basically, you take them out of the body, you engineer them, and then you give them back, and they grow and expand in your body, sometimes for months, up to sometimes over a year, and continue to fight the tumor. So this is kind of a workflow of the process where you do an apheresis and you take the cells off. You do the transfection with the virus, and you send them back. You give the patient some lymphodepleting chemotherapy like fludarabine and Cytoxan, and it makes space for the T cells to have room to expand. Uh, and then afterwards, you can get that same kind of side effect profile where it almost looks like sepsis, where you can get fevers, sometimes some confusion. We call that ICANS. And so these are ways we have to manage them. But the good news is, after it's done, the treatment keeps on working for months and months and sometimes longer. So for diffuse large B-cell lymphoma, there were 3 pivotal trials, and each one was a different product. The Zuma studies were Axi-cel, the Juliet study Tisacel, and then Lysocell. So each of these was for patients that had diffuse large B-cell lymphoma. And basically, they tried moving it into the second line. So if a patient got R-CHOP or Pola R-CHIP and they relapsed within a year, they could get this treatment, this CAR T treatment. And in the studies, it was a randomized phase 3. So the patient either got randomized to a standard of care arm, kind of the investigator had some choices to give chemotherapy, and then eventually on to stem cell transplant or to do CAR T. And you can see how in the outer two, CAR T did dramatically better. There are multiple reasons why the middle one did not seem to have benefit, but basically Axicell and um, sorry, hold on a second. I'm sorry. So yeah, and Lysocell both have benefit and they're used. The Lysocell is from BMS, Axicell from Kite, and there's a dramatic improvement. So it's definitely better than using transplant in that situation. You already tried chemo and it didn't work. So doing high dose chemotherapy with stem cell transplant doesn't seem to work, but CAR T actually can. So this is definitely beneficial. We actually have Kite's product here, Axicell, for patients with relapsed diffuse large B-cell lymphoma and also for follicular lymphoma. So some patients, and CAR T can be used into patients up into their 80s. It's easier than stem cell transplant, but sometimes you still not might have availability or a patient may not be eligible. And so for third line diffuse large B-cell patients, they do have these BiTEs that we talked about. So there's epcoritamab and glofitamab. And so basically these durations of response, like 12 months, this is much better than the alternative drugs. These are a shot under the skin. It's pulling the T cells of the patient next to the cancer cells. And these are really great options. I think the decision is, can you cure them with a BiTE versus CAR T? We do know, if you look back, those flattening of the curves there for the CAR T, we think we're curing quite a few of those patients. For BiTEs, we're not sure. So I think still the benefit would be in favor of using CAR T. But if BiTE is your option, it's a really good option, better than chemotherapy that we've had in the past. So for multiple myeloma, I won't talk about the BiTEs, but there is a CAR T treatment for it, and it's called Carvykti. It's from Johnson and Johnson, and I remember whenever it first came out, and they used it, there was an overall response rate of 97%, which is just incredible. Like almost 100% of the patients responded, and 67% of them completely made their cancer disappear. That CRS, it was the bad kind, the grade 3, the ones where patients were really sick and in the ICU, only happened in 3 to 4% of patients. And so it was originally approved for patients that had had multiple lines of treatment. And so this is the 5-year follow-up of that CARTITUDE-1 study. And you can see, again, there appears to be a flattening. It's interesting. There was a recent editorial in the recent JCO about, are we curing multiple myeloma patients? If there's a flattening of the curve at 5 years, does that mean possibly we're curing them? And I think everybody understands that it may be too soon to know. These patients with myeloma, even after stem cell transplant, in the past they tried allo transplant. Eventually, they always seem to relapse, except for very few exceptions. So who knows? We're not really sure. This is in a group of patients that had 4, 5, 6 lines of therapy. This was the very first study that got approval for the CARTITUDE-1 for Carvykti. But because of that, they said, okay, if it's good when you've used up every other option, what about if this patient has just relapsed? So this is in patients that have had 1 to 3 prior lines of therapy. This is the CARTITUDE-4 study. And basically, they had to have gotten Revlimid, Velcade, and dexamethasone or some combination. And then they're randomized to either a standard of care arm, which would be like Pomalyst, Velcade, and Dex, Darzalex, Pomalyst, and Dex, or they get CAR T with Carvykti. So these patients could actually be second line. So they could have had their first treatment and be on maintenance and relapse and either get Carvykti or get standard of care. And you can see those progression-free survival curves. The top one is for CAR T, so it did dramatically better than the standard of care. And this is basically why it was approved in the second line setting. And so the response rates were high. Actually, side effects were fewer when it was used earlier than when it was used very late lines of therapy. The only drawback for the Carvykti is in a certain subset of patients, it's not really a neurotoxicity, but they get this Parkinsonian side effect where they kind of have a tremor. And if it happens, it can be permanent. It's pretty rare, but whenever you're doing it earlier in treatment, it's much less likely to happen, very low numbers. But that's one area they're looking at to try to reduce that side effect. And so that's the balance is, do you want to try these newer treatments that potentially have some different and concerning side effects versus standard of care arm that, and then wait and leave CAR T till later? I think it is definitely moving upfront more and more in the future. Okay, so we did diffuse large B-cell lymphoma, we did myeloma, and so now we'll talk about CLL. So for years, kind of the standard was FCR, and then there was bendamustine and Rituxan. And then newer treatments came out, ibrutinib, and then later acalabrutinib, zanubrutinib. Several years ago, there was a combination up front, which was obinutuzumab and venetoclax. So it's doing an IV treatment and a PO treatment, and you can do it for 1 year, and it did great. It would put people into a deep remission. And sometimes they could actually, it's like a fixed duration. You do 1 year of treatment. So now I think the standard has moved away from bendamustine and Rituxan and from FCR. So the decision is, do you put people on a BTK inhibitor like acalabrutinib or zanubrutinib, or do you give them obinutuzumab and venetoclax up front? So this was the Amplify study, and it was in newly diagnosed patients. It was in those that do not have the high risk features like 17p deletion. Those should be on a continuous BTK inhibitor. If you have 17p or TP53, they will relapse if you just do a short course of treatment. So you need to do continued as long as they are until disease progression or toxicity if they have 17p. They don't have 17p. This study was saying, okay, we have some options. We could, at the time, they said we can do chemoimmunotherapy, and that was either bendamustine and Rituxan or FCR, or you could do a triplet. You can do acalabrutinib, a BTK inhibitor, venetoclax, and obinutuzumab, which is the next generation's CD20 antibody after Rituxan. Or you could do two drugs, acalabrutinib and venetoclax, just 2 pills. And so the top is the progression-free survival. So the top arm, the pink one, is 3 drugs. It's 2 pills plus obinutuzumab. The next one is just 2 pills. And then the bottom one is like bendamustine and Rituxan or FCR. And so, basically FCR, BR, lose out. That should not be what we're picking in our upfront patients. And below you see grade 3 neutropenia. So even if you do obinutuzumab and 2 pills, you're still getting some pretty bad grade 3 neutropenia, just like chemo. And then with the 2 drugs, you don't get as much. So when you give the acalabrutinib in this study, the 2 drugs, you give it for 14 cycles, and the venetoclax, you start on cycle 3. So you do a run in or ramp up with the acal for 2 months, and then you add venetoclax. And so it's for 1 year and 2 months. That's the total length of treatment. So when you looked at overall survival, interestingly, the top one is just the 2 drugs. The next one down, even though the PFS was better adding 3 drugs, overall survival was a little worse. And I think they think COVID was part of that. Given the obinutuzumab, the patients did worse with COVID. And so basically, I think the take home is 3 drugs may knock it down more, but you might have some more toxicity with neutropenia and infections. And so with 2 drugs, you just take 2 pills. You don't have to do any IV. You can do it for 14 months, and you get these excellent responses. So, so that's all I got. CLL, multiple myeloma, and diffuse large B-cell lymphoma. Hope these were helpful and giving you guys updates. Thanks.